All right, everybody, good afternoon. Thanks for logging on. Today we're being joined by one of my colleagues here at the Yale section of cardiovascular medicine, Dr. Bernardo Lombo. Dr. Lombo is an assistant professor here at the School of Medicine and is the director of a couple of really interesting programs here at the school. So he's part of the team that created the Yale Cardiovascular Global Health Initiative, and this has grown into this group called iTeach, which is the international team of educators to advance cardiovascular health, in which he has there at the top of his slide. And he's also more recently become the director of what he's going to be talking about here today, which is the Chagas Disease Alliance at Yale, which is doing a lot of cool work in this space in regard, and I'm sure he's going to be talking about this. So, in regards to research and also raising the awareness of Chagas disease. So, Bernardo, thanks again so much for taking the time today. I'm really excited to see what you have to share with us.
Oh, thank you very much for the introduction. It's really an honor to talk about a condition like Chagas disease today. Chagas disease is a vector-borne parasitic infection that primarily impacts the cardiovascular system with chronic and potentially fatal effects if we don't treat it. And unfortunately, it affects more than 6 to 7 million people. And most of these patients are actually coming from the poorest regions in Latin America. So it was discovered more than 100 years ago by Dr. Carlos Chagas, a Brazilian physician who, during a campaign against malaria, discovered the parasite that is called Trypanosoma cruzi. And actually, it was named Cruzi to honor his mentor, who was Oswaldo Cruz. So this is a map of the estimated prevalence of Trypanosoma cruzi infection, Chagas disease. It affects the Americas. I mean, most of these patients are from Central and South America. There are not endemic cases described in the Caribbean or in the islands of the Caribbean. So it's very important when we ask our patients where they're from. So most of these cases are coming from Central and South America. The countries with the highest prevalence in the world are Argentina and Bolivia, in red here. And then we have also very high prevalences in Ecuador, but of course also countries like Brazil and Colombia, they have high prevalences of Chagas disease. In Central America, the highest prevalence is El Salvador. So it's estimated that around 65 to 100 million people are living in areas at risk for the infection. In endemic areas, actually, this infection, the Trypanosoma cruzi infection, is usually acquired at childhood. And the problem with this disease is that you can get at childhood and then have this long, it can pass years until you develop like these gastrointestinal or cardiac manifestations. Historically, the transmission has been has predominated rural areas of Latin America. And but more recently, because of migration patterns, so we have seen that it has spread to cities or non-endemic countries, like countries in Europe or the United States. So actually, this is a map of the world where we see that most of the cases are located in Central and South America. But again, now we're seeing cases in the United States, in Europe, and places like Australia and Japan. And that's why we really need to know about what's happening here in the United States with Chagas disease. So on this video, you're gonna see how the transmission happens. So and if this is the vector, this is a triatom, is this insect takes a blood meal from a mammalian host, a human being, and releases trymastogotes in its feces. These actually is very itchy, and actually the patient scratches and creates these little wounds, and the trymastogotes enter the host through the wound or through mucosal membranes. Inside the host, the trymastogotes invade cells and they go to, for example, myocardial cells. They go to other type of cells in the organisms, like macrophages, like muscle cells, and they can be there for years. So, and again, unfortunately, it attacks at night while we're sleeping, right? And in some countries, it's called the kissing bug because it likes to bite in the face. And unfortunately, these insects, they live in the ceilings or in the cracks from the walls in houses that are made of palm tree or mud, and that creates the perfect environment for these vectors, the triatons, to live. And these vectors contain the Trypanosoma cruzi. So it's transmitted when the feces of an infected vector enters the mammalian host. The transmission occurs mainly through a bite of these vectors, but may also occur by blood transfusion, transmission from mother to fetus, oral ingestion also of contaminated foods, or organ transplantation. So there is here in the United States, is an emerging disease. An estimate of 100,000 infected persons living in the United States. Most of them acquired the disease while residing in endemic areas in Latin America. Many Trypanosoma cruzi infected individuals have moved from these endemic rural villages to the big Latin American cities or to non-endemic areas like Canada, US, Europe, Australia, and Japan. And as we all know, there's a significant number of residents from Latin America here in the United States. So Trypanosoma cruzi infected vectors and animals are found in many parts of the United States, especially in the south part of the United States, but rare cases of locally acquired vector-borne transmission. And this is because of better housing conditions and less efficient vectors that may explain this low-risk vectorial transmission. But there is a study that shows that could be a prevalence of locally acquired infections based in 1 to 354,000. So, but the main infection routes here in the US is through organ transplantation, blood transfusions, and mother-to-infant transmission. That's why it's very important to offer diagnostic screening to every children of a seropositive woman. And actually, the FDA in 2006 approved a screening test for blood donations here in the United States. So that's very good. So, and just as an example of what's happening in some of our cities here in the US, so this paper actually described the prevalence of Chagas disease in a Latin American population in Los Angeles, California. So from April 2008 to May 2014, they screened almost 5,000 Latin American-born residents in Los Angeles County. They obtained blood samples, they tested for serologic evidence of Chagas disease, and they found 59 cases of Chagas disease, and with an overall prevalence of around 1.24%. And the prevalence was highest from the patients coming from El Salvador. So that's very important to know. And here in the East Coast, there was another article published about the results of a primary care-based screening program in Boston, Massachusetts. So they started to offering education about Chagas disease to healthcare providers. And then they did a screening for patients coming from Central and South America. And they used ELISA. And they found that 3.8% of the tests were positive. But among those positive tests, when they did the confirmatory results, only 26% were positive. So there was a high numbers of false positives. And that only demonstrates the challenges that we have when we screen this medical condition. 3 confirmed positives were pregnant patients, and that's very, very, very crucial to understand the physiopathology in these kind of patients. So this pilot shows that actually it's a good strategy to integrate the screening of Chagas disease in primary care. We need to start always education. Education is the key, not only for patients, but for primary care physicians. But they found a high false positive rate in the screening test, highlighting the needs of improved serologic testing options. So again, unfortunately, Chagas disease is we have more than 100 years, but there is not a good way to diagnose it, not a good way to screen it, not a good way to treat it, and still a lot of things from the biology that we don't understand. And why, as cardiologists, why are we involved in the management of Chagas disease? Because unfortunately, Chagas cardiomyopathy is the most significant clinical manifestation of Chagas disease. It's an acquired inflammatory cardiomyopathy. There are three key pathological processes. There is inflammation, cell death, and development of fibrosis. Every time that we evaluate a patient with suspected Chagas, obviously an excellent medical history, including evidence of potential exposure to Trypanosoma cruzi, depending on where our patients used to live. Obviously, throughout the review system, we need to look for any suggestive symptoms of cardiac arrhythmias or early congestive heart failure, a complete physical examination, always a baseline 12-lead EKG, and a baseline transit cardiogram. So the diagnosis is made by the epidemiologic history, and you have to have 2 or more positive serologic tests. In the acute Chagas disease, the infected persons, they pass through this acute phase with mild symptoms, and it's kind of like a viral symptom. It's like non-specific febrile illness, and a lot of the acute infections actually they are unrecognized. This acute phase can go to 4 to 8 weeks, and actually, when in some of these cases, because as we show, the transmission can be through membranes. So we can have the classical Romagna sign, that is the unilateral eyelid edema, and that is very characteristic of Chagas disease in patients coming from Central and South America. It's very important to identify this acute phase, because actually we can with a high rate of success. So, and the 2 options that we have for treatment are benzimidazole or nifortumab. In this acute phase, there is a generalized immune response with diffuse lymphadenopathy, hepatosplenomegaly. There is a high parasite load, and actually there is inflammation of the myocardium with myocyte necrosis and interstitial edema. And actually there is a risk of mural thrombosis, and sometimes there is involvement of the cardiac conduction system. Not uncommon, these patients that have significant conduction disease. Now, in the chronic Chagas, that can last for decades. So 20 to 30% with chronic Trypanosoma cruzi infection, they develop either cardiac or gastrointestinal complications. And it's thought that approximately 2% of infected persons will progress to Chagas cardiomyopathy per year. And that's why, as cardiologists, we need to be prepared for that. So as a summary, so once you get the infection, either through like a bacterial infection, like the insect, or congenital, or organ transplantation, you go through this acute phase. In this acute phase, 10% of the patients are going to be very symptomatic, and actually there are patients who can die from like acute myocarditis, and it's fulminant, and right. 90%, and this is one of the big problems, 90% of the patients actually, they go asymptomatic or with minimal symptoms, right? So we don't recognize the disease. And the problem is that then you go to this acute phase just only lasts weeks, but then you go to this chronic phase that can last decades, right? And then we go into this, then 70% of these patients that go during the chronic phase, they go to this indeterminate form, right? And you have it for all your life. And 30%, actually, they develop the clinical manifestations, either cardiac manifestation, gastrointestinal manifestation, or of a mix of both. The cardiac manifestations, very important. They develop, these patients, they develop cardiac rhythm abnormalities with sinus node dysfunction, AV blocks, right bundles, ventricular tachycardia, myocardial abnormalities. They can develop significant cardiomyopathies, and with the cardiomyopathies also functional mitral valve disease. They can develop aneurysms, especially left ventricular aneurysms, and they are in a higher risk for thromboembolism and stroke. So EKG, basically the message that I want you to, from this conference is, you see a patient from Latin America, Central or South America, with heart symptoms, like or anything that would suggest that it has a congestive heart failure, and you have right bundle of a left anterior fascicular block, or even a new onset AFib. So think about Chagas. and test for it. And now echocardiography is the most commonly used imaging modality for the detection of cardiac involvement in patients with Chagas disease, even if they don't have EKG changes. The left ventricular regional wall motion abnormalities can be found even in early stages of the disease. Most of these abnormalities are in the apex, in the inferior wall, or the inferolateral wall. And again, if you want to remember something, this is one of the key aspects. Apical aneurysms are a marker of Chagas disease, and it's of great help to differentiate it from other type of cardiomyopathies. Again, you have a patient with new onset congestive heart failure, you get your echo, and they report you an apical aneurysm, immediately think about Chagas disease. Unfortunately, the late manifestations of Chagas disease are characterized by this global hypokinesis and also dilatation of all cardiac chambers. The systolic ventricular dysfunction is the most powerful predictor of mortality in Chagas disease, like in this case in the video. But again, the most characteristic finding is the apical aneurysms. These left ventricular segmental abnormalities are common in Chagas cardiomyopathy in any stage of the disease. These are located mainly in the apex. So here we can see the transthoracic echocardiogram, and we can see here the apical aneurysm. And the problem is that inside the aneurysm, we can have thrombus and then have strokes. So actually, this is a case of a 45-year-old patient with Chagas disease who unfortunately came with a right arm embolic event. And here we can see the apical aneurysm and the thrombus. So this is the image that you have to remember. Like, take home and remember this image. Now, the apical aneurysms can also happen in other walls, like the inferior wall and the inferolateral wall. So here is an image of a two-chamber view. So this is anterior wall, this is an inferior wall, and then we have this apical aneurysm in the inferior wall. Very strange to see also. And here we have a three-chamber view, with the anteroseptal wall, the inferolateral wall, and here we have the aneurysm on the inferolateral wall. So again, when you see an aneurysm inferolateral wall, when you see an aneurysm in the inferior wall, or the very characteristic aneurysm in the apex, please think about Chagas. And here in the United States, we are very fortunate because we have access to ultrasound enhancement agents. Believe it or not, there is no access to this type of agents in Latin America because the vial is very expensive, almost more expensive than the entire test. So here we can use contrast. It's very useful to make the diagnosis of small aneurysms and rule out the thrombus that are typical in Chagas disease. Speckle tracking and strain is a very useful technique that we can use and it made possible to recognize myocardial damage in subclinical stages of this Chagas disease, especially in these patients that are in this indeterminate phase that can last for decades. So speckle tracking is a great tool. And of course, cardiac magnetic resonance imaging, CMR, is an excellent tool that we can also offer to our patients with suspected Chagas disease. It has excellent spatial resolution, tissue characterization with capacity to identify edema and fibrosis. And also the CMR can provide us pathophysiological information about the disease. And here is an example of the level great accuracy, the severity and the extent of the biventricular involvement, and also the best tool to calculate ejection fraction and again, evaluate these regional wall motion abnormalities. And we can also use gadolinium, that, as we all know, is an extracellular contrast agent that will be distributed to these areas of fibrosis of necrosis. And with the appropriate images, everything that looks black is normal, is an affected heart muscle, and the affected myocardial segments will have an increased signal or brightness, like here in our image. And with these patterns of distribution, so actually there are different patterns that with gadolinium, the distribution that have identified in patients with Chagas disease, especially the subendocardial and the subepicardial distribution. So in heart transplantation, so Chagas disease in heart transplantation is very important to be aware. Cardiac transplantation is an accepted therapy for patients with refractory heart failure caused by Chagas disease. But there is a risk of reactivation of trypanosoma cruzi infection in these immunosuppressed transplant patients. So in a series of 31 patients who received cardiac transplantation for end-stage Chagas cardiomyopathy in the US, 1 was diagnosed with symptomatic reactivation of the disease, and 18 remained asymptomatic but had evidence of reactivation based on the rising parasite load confirmed by PCR. So, and another thing that we need to be aware is that organ transplant recipients who receive an organ from a donor with an infected with trypanosoma cruzi, actually they may also develop acute trypanosoma cruzi infection. So, so there are a series of donor-derived acute Chagas in organ transplant recipients. In a series of 16 recipients of kidney transplant from infected donors, 3 acquired trypanosoma cruzi infection. That was around 19%. And in an investigation of 2 heart transplant recipients in Los Angeles, California, they reported to have trypanosomiasis during the same month, and the organ donors actually tested positive for trypanosoma cruzi. And even here at Yale, a couple of years ago, we have a patient of, it was a 64-year-old man with ischemic cardiomyopathy, status post-transplant, and with a post-op, of course, complicated by fever of unknown origin. And a couple of months after the transplant, he was found to have disseminated trypanosoma cruzi infection. So actually, the donor was originally from Mexico. The patient never left the USA. And in Mexico, there is an estimated prevalence of 3.3 with more than 4 million cases. And unfortunately, we have this donor-derived acute Chagas in an organ transplant recipient, and then in the blood here, it was described the presence of these extracellular parasites, and this was the image of the peripheral blood smear, and here we can see the trypanosoma cruzi. So Chagas treatment, again, we don't have good options. Benzimidazole and Ifortimox are the only drugs that are with proven efficacy against Chagas disease. They're very difficult to manage because they're very toxic. I mean, a lot of side effects, so the patients they don't tolerate it very well. And neither drug is approved in the United States. Both can be obtained from the CDC and used under investigational protocol. So it's not just putting the order for it. So you have to go through a process. But definitely the drug therapy is recommended in all cases of acute and congenital infection, reactivated infection, like those cases, and children 18 years old or younger with chronic trypanosoma cruzi infection. Unfortunately, for patients with advanced Chagas cardiomyopathy, that a lot of times they're the patients that, as cardiologists, we're seeing, antiparasitic treatment is not recommended because the existing pathology will not be affected, and the focus is supported therapy and like offer these patients everything that we in the armamentarium that we have currently to offer to our patients, GDMT when necessary, like the pacemakers when they have advanced conduction disease, etc. Unfortunately, the benefit study that a lot of us, we were having a lot of hope on it, it was published a couple of years ago in New England Journal of Medicine, demonstrated that the therapy with benzimidazole in patients with established Chagas cardiomyopathy significantly reduced the serum parasite detection, but unfortunately didn't significantly reduce the cardiac and clinical deterioration after 5 years of follow-up. The outcomes, I mean, these patients, the presence of this apical aneurysm is associated with a high risk of a stroke, and the stronger predictors for mortality are congestive heart failure, cardiomegaly, the left ventricular systolic dysfunction, and the presence of ventricular tachycardia. So because of all these, here in the United States, we're in a unique position to start helping advance with the collaboration and with our scientists and great doctors from Latin America, actually start doing things to advance in the therapy and treatments for this disease. So that's why we created Chagas Disease Alliance at Yale, CDAY. We are a network of allied researchers, healthcare providers, and public health professionals, and we work in advanced basic research, translational research in Chagas disease, increase the screening and diagnosis of Chagas disease, provide comprehensive clinical care of these patients. So look what we did when we worked together and with appropriate support with COVID. I mean, in less than a couple of years ago, we were able to understand the pathophysiology of the disease, the cycle of like the virus. We were able to have a great therapies great tools to diagnose it, and even we have a vaccine. It has been more than 100 years ago, and we cannot say the same thing about Chagas. There is everything to be done in Chagas disease. So, because due to increased population mobility, migration patterns in recent decades, coupled with climate change, actually the insect vector's habitat is expanding, a consequence of these changes in our weather. So Chagas disease is now a very important public health concern, not only Latin America, but also here in the United States. And in CDE, in the Chagas Disease Alliance at Yale, we think globally, but we add locally with ongoing research collaborations both in New Haven and Latin America. So in New Haven, we started some local projects about the screening of Chagas disease in our populations with congestive heart failure. And also, we wanted to see how much we knew about Chagas disease. And we have this project with Erica Ryak, who was one of our School of Public Health students. And we have also projects in Argentina, Brazil, Colombia, and El Salvador. So Erica Ryak, so what she did is like, let's see how much we know about Chagas disease here in Connecticut. So she did this research project, Chagas disease screening, awareness, practices, and perceived barriers among healthcare workers here in Connecticut. So almost 100 physicians consented and complete the survey. So a series of questions about how much you know about what is Chagas, the therapies, and how to diagnose it. Big surprise, actually 5 out of the physicians who actually, or healthcare workers, never heard about Chagas disease. They didn't know how to diagnose it. What was it? So that was one first thing. Now, she evaluated the knowledge about the disease, the screening practices, and the perceived barriers. So actually, the infectious disease specialists are the ones who score the highest in knowledge, and then the cardiologists. But actually, the healthcare providers in primary care, they didn't know a lot about the disease. They didn't screen for it, and actually, they were the ones who described a lot of barriers in the management of these patients. So, and this graph actually really correlates the relationship between knowledge and screening practices. So basically, if you know about the disease, you're going to screen for it. So that's why at first, we have a huge opportunity here to actually start with this, what we're doing today, educating about Chagas disease, raising awareness. So you think about that. And I'm sure after this talk, you see a patient from Latin America, especially Central and South America, and you have EKG abnormalities of apical aneurysm, you're going to test for Chagas. So in some of our international projects in Latin America, we have this project with Argentina, with Hospital Privado Universitario de Córdoba and the Instituto Universitario de Ciencias Biomédicas de Córdoba, with Yale School of Medicine and Yale New Haven Health. So here's a picture of the multidisciplinary team of students and residents from Yale and from Hospital Privado. So we conducted a descriptive cross-sectional study in the town of Brete, that is with a population of more like 1,700 people in Córdoba, in the north part of Argentina. We described the sociodemographic and anthropometric data of 128 volunteers. We were able to obtain serological and molecular biological studies with ECG and echocardiogram. And imagine going to an endemic area in the north part of Argentina, and actually 55% of those patients actually had evidence of Chagas disease. 49%, they have changes compatible with Chagas cardiomyopathy, with abnormal left ventricular functions or larger left ventricular size and abnormal EKG changes. So actually, this study demonstrated that it's practical to actually go and screen for Chagas cardiomyopathy in endemic rural areas with EKG and echocardiogram. Because remember that one of the problems of these communities is that they live very far from hospitals or clinics, so they don't have good access to healthcare. And now another revolution that we're going through in cardiac imaging is that now we can carry out this tablet that you see in the picture. So Bob McNamara is using this tablet ultrasound to screen for Chagas cardiomyopathy. These tablets, actually, they have the same capability of one of our big echo machines in the hospital. So it's very useful to this type of projects. We find a high prevalence of Chagas disease cardiomyopathy in this community. And in order to have an ideal program, this should be the structure. In order to guarantee a high impact, these programs, they need to have sustainability. It's very key that every time that we identify a case, that actually you immediately link this patient to the local healthcare system. That's why it's always very beneficial to have your local authorities and local universities to work with you and have this long-term relationship. And education. Education is the key. With this program, we want to consolidate our educational cooperation to share knowledge in cardiovascular medicine with local physicians and scientists from Latin America, and hopefully improve population health. And we want to have this longitudinal and sustainable relationship in where we increase the health promotion, we increase the screening for the disease. And one key thing is that we need to advance in basic Chagas research. I mean, there is not, one of the big problems in Chagas is that we don't have even a good animal model where we can prove therapies, because, and that's just one example of a lot of the barriers that we have. It's key to train medical doctors in the management of this cardiovascular condition. So just to finish, so recently in our group, I mean, we have a small grant to actually do some studies with our partners in Argentina. We're gonna try to describe the genetic polymorphism in immune and inflammation associated with the genes and their association with this patient with Chagas cardiomyopathy. And why, as you remember the natural history of the disease, a lot of the patients that actually they are able to deal with the infection, and only 30% they go to manifest the gastrointestinal and cardiac conditions. So we want to investigate a little about that genetic polymorphism that makes those immune system specials. So now we know that cytokines and chemokines are involved in this immune response to the Trypanosoma cruzi. While they assist in the initial infection to control it, the persistent immune response may cause ongoing cardiac injury, but that changes from patient to patient. The expression of chemokine ligands and receptors is partially influenced by these genetic polymorphisms, particularly the single nucleate polymorphisms, the SNPs, which had been studied in relation to the development of Chagas cardiomyopathy. So the SNP represents a difference in a single letter of the genetic code between individuals of the same species. So our study seeks to investigate the presence of these key polymorphisms that make these individuals special, right? And these individuals that are seropositive to Chagas disease, and evaluate their contribution to see how susceptible they are to develop Chagas cardiomyopathy. We're going to concentrate in two rural populations in the endemic areas in the north part of Argentina, and town of El Brete and town of Chancanay. We're going to obtain complete medical histories and information of the current health status, but also we're going to do a complete cardiovascular examination, EKG, and echocardiogram, and we're going to obtain blood samples for serology and to determine the genomic DNA isolation and determination of these genetic polymorphisms that, and particularly these SNPs or single nucleate polymorphisms that can be associated with the development of Chagas cardiomyopathy. So these SNPs serve as an important genetic marker that can help elucidate the complexities of Chagas disease and other health conditions. They help us to understand this variation, not only to improve our knowledge of disease mechanisms, but also opens avenues for personalized medicine and target therapies. Remember how the CPK9 inhibitors were discovered, right? We will aim to correlate genetic mutations in the population that may promote or prevent the development of cardiomyopathy. We really need to understand the mechanisms that the human body has to face this parasite infection. And I want to finish with this, one of my favorite paintings, the Starry Night by Vincent van Gogh. Actually, he painted this artwork when he was very sick, Van Gogh, in the hospital of Arles in the south of France. And despite that, he was able to create this masterpiece, right? So in similar with Chagas disease, we may be going through a very difficult times, and we don't know a lot of, it's affecting a lot of poor patients in Latin America. We don't have a good way to diagnose it, not a good way to treat it. A lot of things about the biology we don't understand. But despite, I think that it's a huge opportunity. Now is the time. It's a huge opportunity for us to work in partnership with our colleagues from Latin America and do advancements in the therapy and management of Chagas disease. And with this, I want to thank you, Dr. Beasley, and all the organizers for inviting me to share what we are doing in Chagas disease and raise awareness about this medical condition. Here is the website of our nonprofit organization, I Teach, the International Team of Educators to Advance Cardiovascular Health. We base our long-term relationship in education. We train the trainers to treat the world. Thank you very much.
Well, thanks, Bernardo. That was really fantastic. And, obviously can see how passionate you are about this topic. We had a great question that came through at the end in the chat. Since treating the disease is difficult, are you able to speak on any measures in regards to disease prevention that might be important to know about?
Yeah, very, very important for prevention of the disease. Improvement in the housing is key, and control of the vectors. Actually, a lot of countries in Latin America, they have done a great job in the control of the vectors. I mean, the problem is that this is a medical condition that is linked with also poor socioeconomical factors. It's not that easy just to go to a community and I'm gonna replace your house, and improving the house conditions is key. Controlling the vector is key, and also to understand and look for the condition. That's why screening, like do all this screening before the long-term manifestations of cardiac and gastrointestinal consequences is so important, right? But at this moment, yeah, there are also strategies with insecticides, right? So improvement of housing conditions, control of the vector with insecticides are good strategies.
Okay. And then is there any data out there that shows like how effective GDMT is for Chagas cardiomyopathy? Is it as effective as it would be for like another form of dilated cardiomyopathy, or
Yes, I
might
mean,
there?
it's challenging. I mean, and actually, sometimes I get questions about strategies how to treat these patients. But yes, I mean, we need to offer everything we have now for our cardiomyopathies, and we should offer to these type of patients. Sometimes it's tough. I mean, sometimes it's difficult to start beta blockers in patients with low heart rates or with conduction disease and everything. But basically, these are very challenging patients to treat. I mean, and if you work in a CHF service and you are able to see Chagas disease, especially, for example, in the DC area where there is a lot of patients from Bolivia, actually, they have gained a lot of experience in treating this type of patients. But yeah, the idea is that we need to offer everything that we have in our armamentarium to treat patients. The GDMT should be offered to them. Also, we need to be aware that sometimes they have a higher risk for thrombosis. So sometimes we need to start an anticoagulation sooner rather than later.
And then another question just came in: would patients with Chagas be candidates for consideration for heart transplantation?
Yes, patients with Chagas, they can be candidates for heart transplantation, but you need to be aware that with the immunosuppression, you can have a reactivation of the disease. Actually,
Yeah.
believe it or not, our colleagues of Argentina, that's how they discovered that actually you never get cured from Chagas. You get Chagas because you can decrease the parasite load and everything, but then as you saw in the parasite hides. And then when you get a transplant, you get these immunosuppressive therapies, actually you can have reactivation of the disease. So transplant is an option for these patients, but you need to be aware that you can have a reactivation of the disease with the immunosuppressive therapies.
Well, hopefully we'll be able to have good therapies for Chagas patients sometime soon and to treat the underlying problem. As you mentioned, that's unfortunate that we don't have better therapies for this condition that's been around for so long. Well, thank you again, Bernardo, Dr. Lombo, for taking the time to educate us today. Thanks for everybody for joining, and we'll see you again in a couple of weeks.
Excellent. Thank you for the invitation.
Bye-bye.
Bye.